Good afternoon, everybody. Dr. Michael Jacobs here on our Monday afternoon Instagram chat. Today's topic is how good are my eggs? Understanding ovarian reserve. And the first thing that is remarkable about reproduction, reproductive potential is that it's very different in a man and in a woman. In the male, spermatogenesis is an ongoing process that continues throughout life, and that's because there are germ cells in the testicle or stem cells that constantly produce new sperm. And as you're constantly producing new sperm, part of that division process is to replicate itself and always produce more sperm, and then some of those sperm undergo a meiotic division to form the germ cells to form spermatids and then spermatozoa. On the woman's side, it's a little different. A woman is basically born with as many eggs as they're going to have, and at that point they're called primordial follicles. And if we look at the number of oocytes present in an ovary in a woman, actually the most oocytes that are there are actually when you're an embryo, basically a fetus, at about 20 weeks of gestation. There's probably millions of follicles present. By the time birth occurs, you have about 1 million eggs in the ovary. And by the time you start menstruating at puberty, you're down to about 300,000 eggs. Now, normally, you've got 300,000 eggs. You start menstruating one a month, basically. So you use up 1 egg a month in reality. Use up less if you're on birth control pills, because theoretically you're not ovulating at that time. And you only ovulate for, 35 years or so. And so you ovulate maybe 450 eggs in one's lifetime, but yet you have these hundreds of thousands of eggs that sort of disappear over time. And if you look at the number of oocytes in the ovary at age 38, down to about 25,000, and at menopause it's under 1,000. So it's this constant depletion of an egg source. And it's not just from ovulating these eggs, obviously. It's from a process called apoptosis, where the eggs just degenerate and go away. So that rate at which eggs sort of undergo this degenerative process is very variable from individual to individual. And that's why you don't see all women starting menstruation at exactly the same time and ending menstruation at exactly the same time. So the rate at which the eggs go away determines kind of the tail end of things. Is when you sort of are depleting that egg supply, and the reserve in the ovary is less rather than more. So the first thing to understand is the question of ovarian reserve is really a concept of how much oomph there is in that ovary, basically. And it's really, we can look at markers of ovarian reserve as a prediction of how good an ovary is. It's not going to answer the question, am I fertile or infertile? The ovary and reproductive potential in a woman is more of a dimmer switch than a light switch. It doesn't just go on or off, but it decreases as time goes on and as a woman gets older. So what are the key markers, and what does it tell us? The first thing we always ask somebody is how old they are. And age sort of trumps everything. In a young person, more often than not, you're going to have better ovarian reserve than somebody who is more mature, and more mature meaning 35 and above, let's say. And most people who are 25 or 30 years old are going to have good ovarian reserve. If you look at women 38 to 40 years old, there's going to be a lot of variability. Some will have okay ovarian reserve for their age, some will be good ovarian reserve, some will be really bad ovarian reserve. So age is the first thing. And then there are some biologic markers that we can use. Anti-Müllerian hormone testing, which is a blood test called an AMH level, is utilized to give us a sense of where you are. And although there's a lot of variation at any age of AMH level, a good value of AMH is felt to be, above 2, and most women will be in the 2 to 4 or 2 to 5 range, basically. When you get values of 5 or above, it's really high, and those are most commonly associated with polycystic ovarian syndrome, where you have lots and lots of eggs in the ovary and lots of antral follicles that produce the AMH hormone, so the values are higher. But a value of 2 to 5 in general is a good value at any age. A value under 1 is considered diminished ovarian reserve, and the lower the value, obviously, the less ovarian reserve that you have. Now, if you're 25 and you have a value of 1.8, that would be considered a borderline low value. But if you're 43 and have a value of 1.8, that's not bad. So you have to look at the value, what you expect for your age. Normally the value is going to go down as you age. And so if you have a decent, a value where like 1 and you're 44, that's not bad. But if you're 35, it's a disaster. So in general, 2 to 5 would be a good value. Under 1 is a concerning value. And values will either be consistent with age or suggestive of less ovarian reserve. The second set of blood tests that can be done are FSH and estrogen values, and those are pretty much cycle dependent. They need to be done on days 2, 3, or 4 of the menstrual cycle, counting the first day of flow as day 1. And in general, a high FSH with a normal estrogen level is not a good sign. So low AMH, high FSH is concerning. Estrogen levels should, and at that point of the cycle, should really be under 60. FSH levels under 10 are normal, up to 12 reasonable, above 16 very concerning for how the ovary will respond to fertility drugs and the life that's in the ovary. And the next marker is not a blood test, but it's an ultrasound. And the ultrasound similarly needs to be done on days 2, 3, or 4 of the cycle. And by looking at the ovaries at that point of the cycle, one can get a sense of the ovarian size, and more importantly, to do what's called an antral follicle count, which is to measure the little black spots that are in the ovary where the eggs live, these little black lakes. They go from 2 to 10 millimeters in size, and a normal antral follicle count will be 5 to 10 per side. Now, if you have polycystic ovaries, you're going to have over 12 per side, and often you'll see 20 or 30 on each ovary. So, a good antral follicle count, is 5 to 10 per side. When it gets above 12 or 15, we worry about too many antral follicles, and that's often associated with higher AMH levels. AMH levels tend to be fairly consistent within the same lab. There's very little variation throughout the menstrual cycle. It should be within 10% or 15% from cycle to cycle, basically. But different labs use different standards for AMH level. So if you send the same blood sample to 3 different labs, you may get 3 slightly different answers. Now, what's not going to be different between those labs is the general trend. You may see, for instance, let's say if someone has a value of 1.6 in one lab and it's 1.4 in another and 1.9 in another, that would be anticipated, but you're not going to see somebody having values of 0.3 and 0.2 in one lab and values of 4 in another. So the trends will tend to be the same, although the exact numbers may vary from cycle to cycle. FSH and estrogen values vary very much so during the cycle. There tends to be some consistency from one cycle to the next, but the actual values, again, will change a little bit cycle to cycle with that. AMH is felt to be a little more sensitive in telling us that what the ovary is going to do than FSH and estrogen. And antral follicle count is also helpful. So what do these things mean? If you have a good AMH level, you're younger rather than older, you have a normal FSH estradiol level and a normal antral follicle count, you have good ovarian reserve. What that means is that the potential of the ovary to respond to fertility drugs if challenged in that way is good, and it should produce more rather than less eggs. If we're doing IVF, where we're trying to stimulate to get a lot of eggs to be produced, it will be beneficial in allowing us to try and adjust the dose of medication to get the best possible response. If you have a low AMH or high FSH or low antral follicle count, or you tend to be older, let's say over 38, our expectation is you're going to respond less well with medication, so we need to give you higher doses of medication to get the same response. And also, particularly in women over 35 with low AMHs compared to the same age group with equal AMHs, you tend to see patients when they have higher, if you have abnormally low AMH levels at the same age, over age 35, you tend to have higher aneuploidy rates in embryos. So remember, when we're trying to get people pregnant, particularly with IVF, the first thing is how many eggs are we going to get, and that's good. These values help us determine how to treat you to get the most number of eggs that we can. And then the second factor is when these eggs start functioning, are they good eggs or bad eggs? And again, they aren't necessarily bad eggs, but eggs that result in abnormal embryos, which are called aneuploidy, because when division occurs, you get a mess up in the division of the embryo, so you have the wrong number of chromosomes present. And as a result of the aneuploidy event, you have an abnormal embryo, and abnormal embryos tend not to develop. If they do stick, they'll miscarry, and rarely will result in an abnormal baby. So in brief and in summary, what are these tests for? Ovarian reserve is a concept of how much vibrancy there is in the ovaries, so that if challenged with fertility drugs, is it going to respond easily or be more resistant to that challenge? You can translate that in layman's terms as being more fertile or less fertile, but we've gotten people pregnant with 2 or 3 eggs as much as 20 eggs, so it depends on the quality of those eggs as well. So low AMH, higher FSH, low antral follicle count, increased age. Those things correlate with diminished ovarian reserve and a bigger challenge to us in how we treat you. In patients with normal AMHs, normal FSHs, younger age group, and normal antral follicle count, we'd expect a good response to fertility drugs and an age-expected response as far as aneuploidy. In women that have very high AMHs, this means they're going to be more sensitive to fertility drugs. When the values get over 5, we worry about whether they're polycystic ovarian syndrome or not. And all these things just help us guide our treatment of how much fertility drugs to give you, as well as how aggressive we might be in moving on to more direct treatment. And in that sense, if we're dealing with somebody who has lower ovarian reserve, it makes sense to think about doing things such as IVF sooner rather than later, because ovarian reserve is only going to decrease as time goes on. Another way we look at ovarian reserve are patients that are older, depending on how many children they want, and they're doing IVF. Let's say we have one embryo from an IVF cycle, and it's a normal embryo genetically, which has a good chance of working. If the couple just wants one child, they might as well just put that embryo back. But if you've got somebody who's 40 years old or 41 years old, or even somebody who's 35 with low ovarian reserve and low AMH, and we have that one embryo, but they want to have 2 or 3 kids, it may pay to get more embryos before doing another cycle to get more embryos by doing another cycle of IVF and stimulation before putting an embryo back in. Because once that embryo goes back in, if you're pregnant, remember, you got a pregnancy that lasts 9 months, you got to give birth, we got to wait 6 months before we can treat you again after giving birth. and now you're a year and a half older and your ovarian reserve is a year and a half further down the road than when we started the process. So knowing the ovarian reserve helps us counsel you and guide you in making those decisions as well. So I hope this brief discussion of ovarian reserve is helpful. Please review, if you have questions, review it with me or your doctor. It's helpful for us to understand how much of an expected response to get and how to adjust our medication doses when we have you on fertility drugs. And particularly if values are low, and it suggests that you have diminished reserve. If you're not trying to get pregnant right now, consideration for egg freezing is better sooner than later in that situation. And obviously, if you are trying to get pregnant, not succeeding, being a little more aggressive and more direct with therapy is the better, more successful way to go. So have a good afternoon, be safe, and have a good day.